Good evening. Our panel, our powerhouse panel over here, has three members this evening. Gentleman closest to me is Dr. Joe Gamboa. Dr. Gamboa hails from Cerritos, California. He did his medical school training at Loma Linda Medical School and residency in internal medicine at Huntington Memorial Hospital in Pasadena and rheumatology fellowship at Loma Linda Medical Center. Dr. Gamboa enjoys performing the violin and piano when he's not worrying about osteoporosis. Next, Dr. Gamboa, excuse me, and I hope you get this first name right, is Dr. Dilrukshie Kure. Close enough? Thank you. She is a rheumatologist here at Torrance Memorial Physician Network. She completed her residency training in internal medicine at Loma Linda University Medical Center. What's with Loma Linda here anyway? In 2003, after which she was chief resident at Loma Linda. She also completed her fellowship in rheumatology at Loma Linda University Medical Center in 2006. She was an assistant professor and associate chief of rheumatology at Harbor UCLA Med Center before she joined the Torrance Memorial team in 2013. And our third speaker, gentleman furthest from me, is Aaron Bright. He graduated from the University of Southern California with a BS in, I hope I've got this, kinesthesiology? Close enough, okay. BA in neuroscience. During his undergrad studies, he worked as a student athletic trainer, assisting in the rehabilitation of football, track, field, and volleyball athletes. After receiving his bachelor's degree, he then went on to continue his studies at USC, attaining his doctorate in physical therapy. While in grad school, he became a certified strength and conditioning specialist to further advance his knowledge in exercise prescription. Aaron's an active member of the California Physical Therapy Association, serves as the chairperson for the South Bay Long Beach District. Aaron currently works as an outpatient physical therapist for Torrance Memorial, focusing on musculoskeletal rehabilitation. So our first speaker is Dr. Gamboa. Please help me welcome Dr. Gamboa.
Good evening. Thank you all for coming. And my name is Dr. Joe Gamboa, and I'm one of the two rheumatologists at Torrance Memorial Physician Network. I'm here with my colleague, Dr. Cooray, and today we'll be talking about osteoporosis. Do I have it, and where do I go from here? Specifically from a rheumatologist's perspective. And afterwards, we have Dr. Aaron Bright, who will talk to us more about the physical therapy side. So the way it's laid out is I will first talk about the background of osteoporosis, then Dr. Cooray will talk about the treatment of osteoporosis. So I want to first start out by saying, well, what is osteoporosis? Well, it's defined as a severe loss of bone mass. So what does that mean technically? Well, the picture that I want to paint to you is think about the bones in your body and what purpose it serves. I would argue that it serves as one of the things is as a structure of your body, to add a structure or foundation for your body. A lot of things in your body attach to your bones, such as your muscles, such as your tendons, to allow you to move and do your daily activities. So your bones need to be really strong in order to provide structure for your body. In osteoporosis, the structure or the strength of the bone is kind of less, so that it's unable to provide full structure for your body. In fact, with osteoporosis, with the loss of bone density or strength of the bones may be unable to withstand the force of your daily activities, such as when you get up in the morning, walking, sitting down out of a chair, or going up and down. And with the loss of bone strength, the bones may not be able to sustain it, and that's when we run into problems. Now, the thing about osteoporosis, though, is that you do not directly feel it. You don't directly feel your bones losing its strength or its density. You may feel it secondarily or indirectly. What do I mean by that? Well, with osteoporosis, you may notice that, hey, I've lost some inches in my height. Usually about 1 inch to 1.5 inches is considered significant height loss. So that is indirectly could be tied to osteoporosis. The other thing that you may feel indirectly with osteoporosis is if your bones aren't strong enough and they break, you will feel the fracture or the bone breaking. But again, that's indirectly. You're not feeling you lose the bone density directly. Now, I don't want you to confuse osteoporosis, which we're talking about with bone density and strength, with osteoarthritis. They first start with the same osteo, which is like bone. However, osteoarthritis directly deals with joint pain and wear and tear of the joints. It's not related to the bone density, rather the fact that you can wear out your joints, especially if you use it, and with the wear and tear, that directly leads to joint pain. So they're different. So when you say I have osteo, you kind of have to specify, do I have osteoporosis, which is bone density, or do I have osteoarthritis, which is more joint pain and wear and tear? So how are we able to determine if you have osteoporosis? Well, if you've been following, you would have to look for the bone density. And we do that by a density scan, also known as a dual energy X-ray absorptiometer, or a DEXA scan. So this looks at the bone density because that's osteoporosis and that's what it deals with. Sometimes you can diagnose osteoporosis kind of by the end game with the fracture of the bone. Because if you fracture a bone, it may be due to the fact that your bone is not strong enough to sustain all those forces, and you do have osteoporosis. So this is kind of a quick introduction and overview of osteoporosis. But this is a picture representation of osteoporosis. This is actually your left femur or left hip, and on the left, you could see is normal bone. It's very dense, very strong. It's a good hip. It can sustain a lot of forces. Sitting up and down out of a chair, getting up out of bed, squatting, etc. But with osteoporosis, you lose that strength, that density. So you can see there's more holes, looks like it's not as stable, and this is more prone to breaking, especially if there's a lot of force being placed on your left hip. And here's another picture of the progression of osteoporosis. On the very left is a normal bone. So again, very strong, can sustain the daily activities, whatever your choice is. But then as osteoporosis progresses, it gets more holey, less dense, and as you can see, a lot more prone to breaking at that point. But this is osteoarthritis, so a little different, actually a lot different. So this has to do with the wear and tear. These are your knees. And the wear and tear of the knees in the inner aspect. So that's wear and tear. We're not talking about bone density, we're talking about the joint spaces. And this wear and tear, loss of joint spaces, can lead directly to joint pain of the knees. These are the osteoarthritis of the hands. You lose the spaces on the tips of the fingers. And this can lead to pain. Also looks like some swelling or nodes of the fingers because it's worn out. And this leads to hand pain. But this is not osteoporosis. I just wanted to put this up there to indicate the difference because a lot of people interchange osteoporosis with osteoarthritis, and you can see there's a significant difference. We're talking about different things here. But I want to talk about the topic of the night, osteoporosis. So in order to understand osteoporosis, we have to understand what goes on in your bone on a day-to-day basis. Well, there's a cycle that goes on in your bone day in and day out. It's called the bone remodeling cycle, and what happens is that first, your bone is constantly being broken down. This is called bone resorption, and it's done specifically by cells called osteoclasts. But don't fret, because your bones aren't just being broken down, they're still being built back up. And this is called bone formation, and it's done by cells, specifically called osteoblasts. And this is in equilibrium. Your bones are being broken down and built back up, broken down, built back up in constant equilibrium on a day-to-day basis by different cells. And it's important because this is osteoporosis is affected by this, and even the treatments are affected by this. So just keep this in mind. And if you don't like cycles, this is a linear way to look at what happens in the bone. Your bone is being broken down or reabsorbed by osteoclasts and then built back up by osteoblasts or bone formation. So in osteoporosis, which is low density of the bone resorption takes precedence. Bone resorption happens more so than the bone formation. Therefore, your bone is being broken down more so than being built back up. This leads to bones being thinner, loss of structure, and being more prone to breakage, and can lead to bone fractures. In fact, I'll reiterate this, we can even diagnose osteoporosis, which is indicated by bone fractures. So here's another picture representation of osteoporosis. This is your spine, and your spine is made up of a column of vertebrae. These are the boxes, and in between are discs. So in a normal vertebra, again, it's very strong. It's able to help with your posture so that you can sit or stand up straight. It helps when you walk so that you're standing up straight. However, with osteoporosis, you lose the strength of your spine, so it's more prone to breaking. In fact, we call it, there is a fracture, a compression fracture, because it is compressed, because it's unable to hold up all the heavy load that your spine needs to undertake on a day-to-day basis. And compression fractures, you could see, it squeezes the vertebra, the box, and that's where you can lose some of your height. So again, going back, you may indirectly notice that you're losing some of the height, and it may be due to a compression fracture from osteoporosis. And this is how it's looked on an x-ray on a normal vertebra. It's nice and square, very strong, able to help you stand up straight, you feel tall, but with a compression fracture, you lose that height, you lose that stability, and that could be an indication for osteoporosis. Here's another fracture from osteoporosis, and this again is our friend the left hip. Now the hip or femur attaches to your pelvis from what's called the femoral head. In between the femoral head and the rest of the femur is something called the femoral neck, right here, and that is more prone to fractures with osteoporosis. Your hip sustains a lot of pressure, a lot of force as you get up, sit down, do your daily activities, so there's a lot of pressure in that area. And if your bone isn't strong or dense enough, it can break, and it's usually in the femoral neck. And here is a radiograph or x-ray indication showing that break in the femoral neck. So that can happen with osteoporosis. So it's important to know what's going on in your body. So what are the risks of osteoporosis? Now you know that, okay, osteoporosis is loss of bone strength, it's not dense, it's not strong. What are the risk factors that can give rise? Well, we found that advancing age is a big one. As we get older, the bones are not as dense or not as strong. It's thought maybe it could be related to sex hormones, because as we get older, our sex hormones go lower. For females, that's menopause, they lose estrogen. For males, they can lose testosterone. So that may be an indication. Another big indication or risk for osteoporosis is family history. If you have a family history of osteoporosis in the genes, you may be more prone to severe bone density loss, leading to osteoporosis. So that's why it's important to know your family history and your doctor to ask about your family history. Also, eating disorders, anorexia, bulimia. If you're not taking enough nutrients into your body, your bones don't have the right building blocks to become strong, to withstand all the forces. Also, cigarette smoking has been associated with osteoporosis, as well as alcohol abuse. Low calcium and vitamin D, which we'll talk about, but that can also be associated with osteoporosis. A sedentary lifestyle. Because if your bones aren't stimulated to be strong, why would it be? If you're sitting on the couch all the time, what indication does your bones have to be strong? If you're moving, being active, then your bones have a stimulus to become stronger, and hopefully will become stronger. And lastly, medications, specifically steroids, can directly lead to osteoporosis. There are also some diseases that can give rise to osteoporosis. These are lectures or miracle of living in and of itself. However, I did want to mention some. They come in endocrine diseases such as hyperthyroidism. So if your thyroid's high, it can give rise to osteoporosis. Hyperparathyroidism. The parathyroid are glands in back of your thyroid that regulate calcium. So if it's regulating too much calcium, it can eat up the bone and cause osteoporosis. And Cushing's disease, which is when your body intrinsically makes a lot of steroids, that too can give rise to osteoporosis. Two other diseases that rheumatologists are familiar with are inflammatory arthritis. This is when your immune system, same immune system that helps you fight off an infection when you're sick, decides to attack, instead of a bacteria or a virus, attack your own body. And when rheumatoid arthritis, it attacks the joints. In ankylosing spondylitis, it specifically likes to attack the back, sometimes the pelvis and the hips. So these cause inflammation, and of course, inflammation of your joints and bones can lead to osteoporosis. But again, these are lectures in and of itself, but I did want to mention it because when you're checking for osteoporosis, you want to see if you have this. Is this the underlying cause for osteoporosis, or is it the other things that we mentioned on the previous slide? So who usually gets osteoporosis? Well, if you are following advancing age, and usually, like we said, when the sex hormones go down, so postmenopausal women usually get it, and usually around 50 is around the menopausal age. For men, it's usually over the age of 70. Now, this is just an average. You could be higher, could be lower. But in the United States, about more than 4.5 million women over the age of 50 have osteoporosis. Over 800,000 men greater than the age of 70 have osteoporosis. So it's pretty prevalent. So now, how should we diagnose osteoporosis? Well, you kind of know the answer to that. We need to see the density of your bone, and we check the bone mineral density of a given area by the dual X-ray absorptiometry. And we do this by looking at the parts of the bones that need to be the most dense and get the most force in them. So the lumbar spine is a big one because it has to hold up a lot of your body as well as your hips, and they're also prone to fractures, as you know. The hip that we mentioned is the femoral neck, which is the upper part of the thigh bone. And then again, if you have a bone fracture, that can also help us diagnose osteoporosis because of all the force that your joints and bones have to endure. So when should we get a DEXA scan? Well, the National Osteoporosis Foundation recommends that women 65 years or older should get a DEXA scan because of the age. Menopausal women can also get it if there's risk factors, because you have to figure out what are the risk factors that you have for osteoporosis. In men, we mentioned 70 years old because that's when the testosterone goes down, or definitely if you break a bone after the age of 50, because that can indicate that there would be osteoporosis, and we need to know what your density of your bones are. So how does a DEXA scan work? Well, it's painless, and it uses the same X-ray technology, kind of like an X-ray. So pregnant women are recommended to avoid it. But it focuses on the hips and the lower back. At times, it can focus on the forearm. That's usually done when there is a disease such as hyperparathyroid that we mentioned for the forearm, because it likes to eat away the forearm. But for this intents and purposes, we're focusing on the hips and the back. And this is how a DEXA report looks. The big thing or take home that it comes out from it is that it gives what's called a T-score, which is determined by your age, race, and also your sex as well. And we'll talk a little bit more about that, but that's the big take home from a DEXA scan. We get to know the T-score. I will mention that sometimes you may see what's called a Z-score. A Z-score is usually used for younger patients that we don't expect to have osteoporosis, but may have risk factors for osteoporosis, such as the medications they're on and or the certain diseases that we mentioned. So in those cases, we use a Z-score. But usually, in all intents and purposes, we're focusing on the T-score, and you're usually able to get a DEXA scan every 2 years, and that's kind of because that's what the insurances will pay for every 2 years. So if you want to know why, that's the underlying reason. So I'm going to mention what the T-scores are, and you may or may not have heard of it. And this is how we determine where you land in your bone density. So if your T-score is not lower than -1, you're considered normal. If you're between -1 and -2.5, you're considered mild bone mineral density, that's BMD loss. So just mild, also known as osteopenia. If you are -2.5 or lower, that is defined as osteoporosis, severe bone mineral density loss. So that's where the T-score comes into play. So you can memorize this, which is very good. If you're good with numbers, hey, I applaud you. Or you could try to understand, what do they mean by this? Where did they come up with these numbers? -1 sounds like a good number, let's use that. Or -2.5. Well, it actually comes from statistics. So going back with the DEXA scan, what happens is that with a DEXA scan, they want to know your age, they want to know your race, and they also want to know your sex. So yes, DEXA scans are sexist. So once they know that, what they do is that they get all the, let's say for example, all the 70-year-old female Caucasian women with that age group, all of them that got that DEXA scan. And as a side note, yes, there are different DEXA scans. There's Hologics, there's Lunars. So different machines can spew out different results. So we try to recommend having the same machine, easier said than done. But that's because it all has to do with statistics. So they get all the population getting the DEXA scan for that age, race, and sex, and they pool it all together. They say, okay, we have a population of everyone in North America, let's say 1 million people that did that. And they put statistics. And if you know anything about statistics, there's always an average. So they say the average, we give that 0. That is the average bone density or bone strength for the Caucasian white female who is 70 years old. And that is where they come up with 0. And if you know anything about statistics, there's always people who are greater than the average and then less than the average. So they put everyone in this graph, it's called a bell curve, and they said, okay, so if you are just -1 below the average, that's still okay. You are still considered normal. So all these people, -1 and above, are considered having normal bone density scan based on the population. Then they said, okay, if you're between -1 and -2.5, you have, based on this entire population, comparatively speaking, compared to everyone, you have mild bone mineral density loss. So compared to the population, you belong here. And we'll talk a little bit about osteopenia next. But then if you are less than 2.5, which is a standard deviation, you're less than 2.5, then the average, which is 0, you're way, way, way low with your bone mineral density. So you have osteoporosis. And that's important because they want to focus on the patients who are more prone to breaking a bone based on that population. And that's the patients who are down here. They're the lowest. So therefore, they are, out of the whole population, the more prone to breaking a bone. So that's where the -2.5 comes from. And that's why when your doctor looks at a T-score, they're saying, where do you land in this spectrum? Are you down here? Maybe you're up here. And that's because if you're down here, based on your population, you may be at the lowest part and you may have osteoporosis based on that. So that's where it comes from. So if you understand where it comes from, it makes sense. So this gives me the opportunity to talk about osteopenia. which is mild bone mineral density loss. It's not as severe as osteoporosis because it's between -1 and -2.5. If you saw the graph, you're not quite all the way to the left. You're just kind of getting there, but you're also not in the normal range. However, you still may have a risk of fractures from it, right? Because you're not way in the normal range. You're getting towards that area, part of the population that is maybe more prone to breaking a bone. So with osteopenia, we take it a step further. We say, hey, you may be at risk for breaking a bone. Let's calculate in the next 10 years the likelihood of you breaking a bone. And that's called a fracture risk assessment, or FRAX score. And that looks at, in the next 10 years, what is the probability of you breaking a bone? And it's split up into two majors, so like any major bone that you can break, and then specifically the hip. So we spew it into another computer, and again, it's racist, sexist, whatever you want to call it. So we'll go with United States, and then they want to know your age, they want to know your sex, they want to know, and then different risk factors for breaking a bone, such as rheumatoid arthritis, if you have a family history, are you smoking, are you drinking alcohol, and so forth. And then out comes the FRAX score, which is, again, is the 10-year risk. In the next 10 years, what is the risk of you possibly breaking a bone? And it comes out in major and hip. So when is it significant? Well, according to the guidelines, it is significant if you have a 10-year risk of a major fracture of 20% or greater. If you do, if your FRAX score, major FRAX score is 20% or more, that tells us you have 20% or more 10-year risk of fracturing a bone. That is significant to us. We recommend therapy. If your hip is 3% risk of fracturing in the next 10 years or greater, then that's significant to us. We recommend treating it as if it will break or osteoporosis. So this is kind of an overview of osteoporosis. You see where it's coming from, what the principles are to determine it, and what steps we take to see if you have it, and the difference with osteoarthritis. So the next part of the lecture will be done by my colleague, Dr. Kure, and she'll go over the treatment plans for it. Okay.
Good evening and welcome. It's great to see so many familiar faces. Thank you all for coming. So Dr. Gamboa laid the foundation of osteoporosis for us very nicely, and I'm going to go over treatment options with you. So the primary means of treatment is prevention. And as you heard, there are many non-modifiable risk factors, but there are some that are potentially reversible or modifiable. So it's important for us to look at these as a means of prevention, primary prevention, or as an adjunct to therapy. So some of the modifiable risk factors, first and foremost, are an assessment of your calcium and vitamin D levels. Realize that calcium and vitamin D are very important for bone health, and so it's important that we're taking adequate doses of these vitamins, and I'll go over this with you in a moment. Inactivity or immobilization, as you heard, is a big risk factor for osteoporosis. So when we're immobile, not only do our bones weaken, but our muscles weaken, and that increases our risk of falling and developing fractures. So weight-bearing exercises are critical in maintaining bone health, and it's important for us to assess, are we doing enough weight-bearing exercises to keep our bones nice and strong? Excessive intake of alcohol is a big risk factor for osteoporosis, and so having more than 2 to 3 drinks a day can increase your risk of osteoporosis substantially. Smoking is another risk factor, as is low body mass index. And Dr. Gamboa did mention that bulimia and anorexia are pretty significant risk factors for osteoporosis. So endocrine disorders are very important to look at. Hyperparathyroidism and thyroidism contribute to a great extent to osteoporosis. Treating hyperparathyroid actually can reverse osteoporosis, and if it is present and treated, you can avert having to be on osteoporosis medication. So this is a very important thing to look at. When we see patients in clinic and they're coming to us for assessment of osteoporosis, we're looking for secondary causes. And thyroid disease as well as hyperparathyroidism are some of the things that we're looking for. Okay, so calcium, as I mentioned to you earlier, is a very important vitamin for bone health. Calcium seems to be very controversial recently. You know, there was a lot of data suggesting its importance, then some data came out suggesting that it may be a risk factor for heart disease. Now we're back to, well, it doesn't really increase heart disease if taken appropriately. So the bottom line is that we recommend to patients in women age 50 and younger that they take about 1,000 milligrams of calcium per day, 50 and older, about 1,200 milligrams per day. In men, 70 and younger, the aim is to get about 1,000, and 71 and older, about 1,200 milligrams per day. So it's important to read food labels. You can get plenty of calcium through your diet. So realize that looking at food labels, if you're seeing 30% of the daily value of calcium, this equals about 300 milligrams per day of calcium. 20%, 200, 15%, 150. There are some great apps. A lot of you have smartphones, and so you can actually calculate how much calcium you're getting in your diets. Green vegetables, whether or not you realized it, are very high in calcium, and I'll go over some of these in a moment with you. Other foods and liquids can be fortified with calcium, so cereals, orange juice, soy milk, almond milk. A lot of these can be fortified with calcium as well. So this table basically goes over the different types of calcium-rich foods. As you can see, ricotta cheese and yogurt are pretty high in calcium. If you're not a milk drinker, there's a lot of other options to be able to get your daily calcium intake. And vegetables. So of all the vegetables listed, as you can see, the green leafy vegetables, collard greens, broccoli, kale, are very high in calcium. And so if you're eating appropriate amounts of these, you might be able to get your daily calcium intake. I've not mentioned it here, but salmon is also a good source of calcium. When we're not able to get enough calcium from our diet, then we may turn to supplements. And so typically the supplements that are recommended should have the USP, the United States Pharmacopoeia symbol, and this basically guarantees purity standards of the calcium. It's important to read serving sizes and realize that sometimes when you're taking lower doses of calcium, it's much better tolerated. Oftentimes patients tell me, I can't take the calcium, it upsets my stomach. So if we try to have them take lower doses, they're able to tolerate that much better. So taking 500 milligrams twice a day may be much better tolerated than trying to take 1,000 milligrams all at once. Side effects can include gas or constipation, and you want to try the brand that gives you the least side effects. Patients often ask me, what is the best type of calcium to take? So calcium citrate tends to have the best absorption. But again, if this is not one that you can tolerate, then choose a brand that you're able to palate. Vitamin D is a very important vitamin for calcium absorption and bone health in general. Low vitamin D can increase the risk of brittle bones and osteomalacia. Now, Dr. Gamboa mentioned that osteoporosis typically does not cause symptoms until you fracture, right? But when osteomalacia is present, patients can actually feel bony kind of pain. And this is typically when the vitamin D levels are pretty low. So the recommendation, and these have been extrapolated from numerous studies, but the Women's Health Initiative, which took place in the late 90s or so, was really a landmark study showing the importance of vitamin D in osteoporosis and suggested that around 800 international units per day in women or men under the age of 50 was adequate, and 50 and older should shoot for about 1,000 international units per day. Now, the caveat is, though, that if your vitamin D levels are very low, you may need to take higher doses. So patients often ask me, well, why is it that my vitamin D is low? I spend a lot of time in the sun, and so why is it that I'm so vitamin D deficient? Well, truthfully, most of us are not out in the sun long enough to be able to absorb the beneficial effects of vitamin D from the sun. And most of us wear sunblock when we're out there, so this actually blocks the beneficial effects of vitamin D. The conventional thinking is that about 15 minutes of sun exposure equates to about 10,000 international units of vitamin D. But you have to kind of balance that with cancer risks, and many people that are fair-skinned can't spend that much time in the sun. And so most of us do end up turning to supplements to get the vitamin D. Certain medical conditions can affect vitamin D absorption: celiac disease, inflammatory bowel disease. These are two important ones that really can affect our ability to absorb vitamin D. Seizure medications, obesity is a risk factor for vitamin D absorption. So these are the ways to get vitamin D. If you can spend time in the sun, that may be a source. Can we get all of our vitamin D from the sun? Not necessarily. Food is not the best means. Unlike calcium, where calcium is absorbed very well through food, vitamin D, this is not the case with vitamin D. So oftentimes we're turning to supplements. So vitamin D2, or ergocalciferol, is a prescription strength formulation of vitamin D. It's 50,000 international units once a week, and typically given for 8 to 12 weeks. Realize that this is not to be taken indefinitely. Usually there's a finite period of time that we give the prescription vitamin D. Why? Because you can actually become toxic on vitamin D. A, D, E, and K are fat-soluble vitamins, so you can actually get too much vitamin D. Vitamin D3, cholecalciferol, is usually available over the counter, and this is the daily vitamin D that you would take. So typically what we do is when the vitamin Ds are very low, then we might use the prescription strength. We get the level up to a good range, and I'll explain to you what our aim is there, and then we maintain patients on the daily vitamin D over the counter. So if any of you have ever had your vitamin D levels checked, the range is quite broad, 30 to 100. But typically we're aiming to get patients' vitamin D levels somewhere between 35 to 45. It's really not necessary to shoot to have patients in the upper levels. If you go above 100, then you're basically getting into toxic ranges, and these can have serious effects on heart and so forth. So what's the data on using calcium and vitamin D to basically treat osteoporosis without using medications? The data's pretty scant. Studies showed no difference between calcium alone or placebo in reduction of fracture in patients with osteoporosis. So using calcium alone to treat osteoporosis is not necessarily a good idea. Vitamin D, on the other hand, if the vitamin D is very low, there may be some thought to replacing the vitamin D and then perhaps repeating the bone density test down the road to see if it reversed. However, we don't have very robust data showing that replacing vitamin D is going to improve osteoporosis and decrease fracture risk. So before I go into the drug classes, I just want to kind of make sure that we touch base on some of these important factors, what to do if you have osteoporosis. Make sure you are keeping up with the preventative measures, taking enough calcium, getting enough vitamin D, exercising, and keeping your bones nice and strong, and fall prevention programs, because at the end of the day, bones become very brittle and there's a high risk of fracture from falling. Rule out underlying causes. Disease states that Dr. Gamboa went over: rheumatoid arthritis, ankylosing spondylitis, celiac disease, hyperparathyroidism, so forth. Look at medications, because some of these medicines have been shown to contribute to osteoporosis. Steroids is one. PPIs, medications like omeprazole or Prevacid, these medications affect calcium absorption and may actually increase risk of osteoporosis. Some patients end up being on these medications for years, for treatment of GERD, and so these can be a risk factor sometimes for osteoporosis. Hormone imbalances are very important to look at, and sometimes treating these may aid with the treatment of osteoporosis. So what are the medications used to treat osteoporosis? They fall into one of three categories. So this slide Dr. Gamboa went over earlier. Most of the medications in the anti-resorptive class fall into this region. So they work on osteoclast to decrease the breakdown of bone. Bisphosphonate therapy involves 4 medications, and I'll go into greater detail of these in a moment. The rank ligand inhibitor denosumab or Prolia, which is an injection that's given every 6 months. serum estrogen receptor modulator, raloxifene, and hormone replacement therapy all act on osteoclasts to prevent bone resorption. Anabolic drugs, Forteo and Tymlos, are the strongest drugs on the market, and they all work on this side of the slide on osteoblasts to lay down healthy bone. So these are thought to be the best drugs at helping to build up healthy bone. Finally, strontium, which is not available here in the United States. It is used in Europe. The data is very weak, and there is very scant data showing potential effects on bone remodeling. However, it's usually very difficult to tolerate, lots of GI side effects, so this is not one that is prescribed here in the United States. So let me just go over the bisphosphonates. I'll give you the generic names, and then I'll give you the brand name. Some may know it by the generic, others by the brand name. Alendronate, risidronate, ibandronate, or zoledronic acid. Some of you may know of alendronate as Fosamax. This is a daily or a weekly pill. Risidronate or Actonil can be taken daily, weekly, or as a monthly pill. Ibandronate or Boniva can be taken daily or monthly. It also comes in an infusion that's given once every 3 months. Zoledronic acid is the most potent. It's also called reclassed. It's a yearly intravenous infusion. And typically we give this medication for no more than 3 years. We don't have head-to-head studies on these agents, so it's hard to claim that one is superior to the other, but we do know that the infused forms of these medications tend to have better absorption and better outcomes overall. So in terms of the bisphosphonates, alendronate, risidronate, zoledronic acid have been shown to reduce vertebral and hip fracture in postmenopausal osteoporotic women. So Dr. Gamboa showed you earlier the difference between vertebral fracture and hip fracture. So these medications all have very good effects on both vertebral and hip. Ibandronate or Boniva has been demonstrated to have improvement in vertebral fracture, not as much in hip fracture. So in individuals that have osteoporosis of the hip, generally this is not considered to be a very good drug. Typical length of treatment is about 5 years, never more than 8 years. Usually after the 5-year mark, we're getting a little antsy and wanting to move on to something else. The oral forms of alendronate, risidronate, ibandronate are, it's encouraged that they're taken on an empty stomach with water only. This ensures proper absorption of these medications. You have to remain upright for 30 minutes to an hour so that it doesn't irritate the esophagus. And they are contraindicated in kidney disease. All of the bisphosphonates are contraindicated in kidney disease, so it's important to know that. Zoledronic acid, or reclassed, is the yearly intravenous infusion. Not to be confused with Zometa. They're basically in the same family. So Zometa is a form of treatment for metastatic cancer. And so if patients are on Zometa for metastatic cancer, we cannot use zoledronic acid in them. So it's beyond the scope of this lecture to go over every side effect with these agents. Every drug, unfortunately, has side effects, and it always becomes a balancing act between treating the disease and trying to avert the side effects. I wanted to go over some of the most concerning ones. So osteonecrosis of the jaw. There's a lot of hype of ONJ and osteoporosis therapy. So this usually occurs when bisphosphonates are used in high doses, for example, in cancer treatment, or they're used for prolonged periods of time. It's important to realize that this side effect actually is very rare. It can occur in individuals who've recently had extensive or invasive dental procedures while on these agents, or if they've had a serious dental infection while on the agents, or if they're wearing poor-fitting dentures. So typically I recommend to my patients before starting these medications, make sure you see the dentist, get a good baseline screening. Any invasive dental work you're gonna have done, get it done before you start the medication. And then typically we try to avoid taking the bisphosphonates for more than 5 years at a time. So that's called a drug holiday. Usually we'll treat for 5 years and then have patients take a break for a year or two, and then they may go back to the medication. Reclassed, as I mentioned earlier, typically only given for 3 years. Other side effects can include GI upset, body aches, and it can be in the joints or the muscles, and flu-like symptoms with zoledronic acid. Atypical femoral fractures have also been described with a lot of the osteoporosis medications. And so typically these occur in the subtrochanteric region, below the femoral head. And this is an uncommon type of a thigh bone fracture. Again, usually when patients are on these agents for prolonged periods of time, if they're on the drugs for more than 8 years. We again try to avert this by treating for no more than 5 years. Denosumab or Prolia is a subcutaneous injection that's given every 6 months. It's a little bit different to the bisphosphonates in that it's considered to be a immunomodulator therapy. It's actually a biologic agent. It's a human monoclonal antibody, and it affects your immune system. It is safe for in kidney disease in contradistinction to the bisphosphonates. Also in contradistinction to the bisphosphonates, these agents actually can be used for more than 5 years. In fact, they actually have 10-year data now showing safety. The thing with this medication is that you can't stop it. So once you're on the medication, for a prolonged period of time, if a patient wants to stop, we actually have to switch them over to another drug with a longer half-life before stopping. Reason being, if you stop the drug abruptly, then the bones can kind of revert back to the way they were and the risk of fracture can go up. Side effects, it can lower serum calcium levels. Patients can develop joint and muscle aches. There can be an increased risk of infection because it does act on the immune system. So we try to avert this by avoiding giving it to patients who have an infection. It also has the risk of the osteonecrosis of the jaw and atypical fracture. So hormones are also used to treat osteoporosis. However, the data is not very robust. Estrogen has moderate quality evidence showing a difference in reduction of fracture in patients who have established osteoporosis. The estrogen receptor modulator raloxifene has been shown to perhaps have an effect in reducing a vertebral fracture, but not hip fracture. These medications can have pretty profound serious side effects, increased risk of strokes, blood clots, heart attacks. So typically we reserve these for patients that have a contraindication to one of the other drugs. But it's really important to make sure that they don't have risk factors for any other disease like heart disease or stroke, things like that. So the anabolic medications that I introduced you to earlier, Forteo or Tymlos, teriparatide, abaloparatide, are a form of a parathyroid hormone, and they stimulate bone formation. They are self-administered, and it is a daily subcutaneous injection. So you're taught to give yourself the injection at home. They're taken for no more than 2 years in a lifespan. Forteo, 2 years, and Tymlos can be given for 18 months. They're indicated only if you have a fracture from osteoporosis or if you have very severe osteoporosis. The contraindications to these are history of radiation therapy. So this is being extrapolated from rat and mouse data. It was shown that rats and mice that were irradiated actually developed a bone cancer called osteosarcoma. So in humans, we do not give these medications if there's been a history of radiation therapy. If there's the presence of hyperparathyroidism or a history of bone cancer in the patient or in a family member, then again, we typically are not using these medications. So, final thoughts. The consequences of osteoporosis can be devastating. The risk of fractures of the spine and hip can lead to chronic pain, disability, increased morbidity, and mortality. It's important to know that after a hip fracture, the risk of mortality goes up to 30% in 1 year. So there is quite an impetus to treat osteoporosis for this reason. Prevention and treatment of osteoporosis, it's important to look at all the different factors that affect bone loss and fractures. Exercising on a regular basis is very important not only for bone health, but to prevent falling. And to protect yourself from falls, it's important to use a cane or walker. It may not be the most fashionable thing, but it can prevent some devastating consequences. DEXA scans, as Dr. Gamboa mentioned earlier, are important to be done as a baseline at age 65 in women, at age 70 in men. But if there have been other risk factors, if you've lost height, these may need to be done earlier. So in terms of treatment, it's important to discuss with your physician what is the right path for you. Especially, sometimes it gets a little bit tricky, especially when you're falling into that osteopenia range as to whether or not you need to be on medication or can you just do it with lifestyle changes alone. So that becomes very tricky and very, very individual. But ultimately, you do need to have the conversation with your doctor as to the right treatment plan for you. So with that, I would love to introduce Aaron Bright, our doctor of physical therapy, and he will go over some important measures for weight bearing.
Thank you, Dr. Kure. Can all of you hear me in the back? We good? Great. So just out of curiosity, how many of you guys have osteopenia? Osteoporosis? Don't know? You? Don't have anything? Great. So I think this is an exciting topic because a lot of times I get patients who get this diagnosis of osteoporosis. They don't necessarily know what to do about it. A lot of times they freeze up. They're worried about a fracture, and so they kind of take themselves out of doing any activity, any recreations, and that's kind of exactly the opposite of what we want. So I want to introduce exercise as a way to buff up your bones. Usually we think exercise as a way to build up muscles, but it's also a very helpful tool to build up your bones as well. So a quick overview. I'm going to talk about the importance, going to talk about a little bit what they discussed earlier about bone remodeling, some factors in that, and the real reason of why we care with the fractures, and then get into some education and exercises and things that you guys can do to take home. So why should you care? So as they mentioned earlier, osteoporosis in itself isn't a very painful condition, but it's really the consequence of it. It's the fractures. And a lot of people who have osteoporosis get the fractures. So 80% of the fractures are due to osteoporosis. And so there is a real reason as to be careful. And it is more common than heart disease, more common than cancer. And 1 in 2 women, 1 in 4 men over 50 get osteoporosis. I'm going to flip that over there. And then I want to talk about exercise as a means to help out. So Dr. Cooray mentioned all the medications that you can take, all the calcium, the vitamin D, which are great supplements. And then this is another avenue for you to pursue to build up your bones. And not only does exercise improve bone strength and mitigate bone loss, but it also improves your strength. It improves your balance, which is a huge consequence. When you fall, that's when you get the fracture. And I wrote a strong relationship between osteopenia and sarcopenia. And sarcopenia is muscle loss, skeletal muscle loss. And so as you get older, you lose muscle. And I believe by age 70, you lose 50% of your muscle mass. So it's a huge, huge problem. And I want to kind of educate you guys as go out and exercise, get your muscle back, and prevent falling from doing these exercises. And so this is a little bit about bones as you age. So as I mentioned, genetics is a huge component. Like 50 to 80% of your bone strength is due to genetics, but there's also a lot with lifestyle and what you do. Exercising, very important, especially early on. So as you see here, in the early ages, teenage years, that's when you really build a lot of your bone up. And as a kind of educational standpoint and prevention, which is the biggest thing for osteoporosis, maybe for your children, your grandkids, have them start doing some type of exercise, some type of jumping technique, because if you can increase your bone mineral density by 10%, you decrease your osteoporosis, or you delay it by 13 years. So that's a huge point to bring up. I know it's a little too late for us now, but there is still exercises and things that we can do now, but it's a little different because when you're a kid and you exercise, you really build up your bone strength. And even if you stop exercising by your 30s, 40s, your bone strength is still high. So instead of being here, you'll start up over here. So as you age, we know bone declines, but then you'll be declining at a much higher point. So the T-scores where you're getting the osteopenia, osteoporosis will occur much later in life. Whereas if you were an adult and you did the exercises and you stopped, the bone growth will also stop. It will kind of revert back. So they've shown in some studies that if you've exercised for a year and then you stopped exercising, it was just like you weren't exercising at all. So very important, you can't just do it once and say, I exercise, my bones are great. No, you have to keep going with this. It's much like brushing your teeth. You don't do it once and you have a great smile. You have to keep doing it every single day, twice a day. Same thing with exercise. You have to do it daily and you have to be consistent with it. And I put here fracture types. So with menopause especially, there's a very rapid decrease in your bone loss. And they've shown that you have more of a decrease in your trabecular bone, which is the inside part of the bone here, all that kind of holes there. And then as you start to age, then it's kind of equal cortical versus trabecular. The cortical is that darker spot around. And the reason why that is important is because it kind of dictates the type of fracture you get. And I say that because a trabecular, which kind of occurs with the whole menopause, that is really prominent in your spine. And so a lot of times when you get the compression fracture, that's something that occurs earlier, which I'll show. And then cortical, which is a big part in the femur and the thigh, the hip, that's where it comes later on and you can get the hip fractures. And they mentioned this, but I just want to touch on a few things. The alcohol is not only one for, so we have the bone breakers, the bone builders, and so the osteoclasts, which Dr. Gamboa were mentioning, those are the bone crushers, so that will be over here, and then the blasts would be the builders right there. And another side note is that with the alcohol intake, it not only kind of lessens your reabsorption for calcium and breaks down the bone, but it also is huge for falls. And so they've shown that if you take more than 2 drinks within 6 hours, that increases your risk for falls by 20%. So just be careful when you are drinking, maybe drink in bed so you're good. Just knock out afterwards. And another interesting thing is the BMI, the body mass index. A lot of times we think about being skinny as a good thing, as you know, you're not obese, so you don't have all these risk factors. But for bone, it's different. If you are skinny, there's not as much weight for the bones to grow. And so if it's less than 21, so body mass index is your weight divided by your height. You can kind of look on an app or look online later. That if it is low, then that increases your risk because you're not loading your bone enough. And another thing is the obesity can be protective for osteoporosis. And they've shown that the fat with obese patients, they have levels of this hormone called aromatase. And aromatase is important when women who go through menopause, they don't produce as much estrogen, or I'm sorry. It's either, correct me if I'm wrong, it's either the aromatase or the estrogen that's in fat. But either way, they produce those stores, so it's released more readily, so it is a protective mechanism for you in osteoporosis. Let's see here. I think they mentioned all the rest, and I'll talk about immobilization in a second. And so here's the big reason why everything matters. And I stole some pictures from Dr. Gamboa that they were really nice. And so we talked about the genetics being a huge component. You can't control what your race is, but being Caucasian is a higher risk than being an African American. And genetics for falling and fractures are important. They found that if you're under 69, that there's a huge family component, that there's a 70% correlation and link. So if your parents, your family members had a fracture, and if you had one, there's a 70% correlation with that. But after 70 years old, there is really no correlation. That's kind of all on you. And the lifetime risk for fractures, this is, I believe, in England and Northern Europe, where I did this, read the study, was lifetime risk was 1 in 2 for females and males 1 in 5. So very, very shocking numbers. So half of the women would get a fracture within their lifetime. And this is where exercise would be, very, very important. And there is a study that showed, it's one of the leading causes of death in the elderly. 20% of people after hip fracture, they don't survive after a year. And I put this on here because I came across it when I was reading some research articles with cataract surgery, that it helped decrease falls by 30% and decrease then the fractures by 40% in those who had the cataract surgery done. So if that's something you need, don't push it off. And here, when I was talking about the difference between the trabecular and the cortical bone, there was a couple studies that showed, so just to orient you, so this is the number of fractures on the top and then the age. And so the blue is the spine fractures, and the green is the hip fractures, and then you also have the forearm fractures, and women and men. And so initially, you have a huge, huge number of vertebral fractures in the spine, and that's what they attribute to that loss in that inner part of the bone, the trabecular part. And then as you get older, a lot to do with the falls, you get the femur and the hip fractures. And that's attributable to the falling. So 95% of the fractures are due to the falls in the hip and the femur. Okay, so another very important thing is the posture. And this is kind of not what we want, but you can see, though, he's all bent over and hunched. And then when you are bent over and hunched, we call that a hyperkyphotic posture, when you're like this. And that becomes very important because it increases the spinal compression. So if this is a normal kind of spine where it just goes straight vertical down, when you're in this posture, it changes the force to be more in the front. And then if you have more pressure in the front, that will then crush the vertebrae below it. And by altering your center of mass. And so another big thing is that it showed that it alters your balance. So if you are forward like this, you're very likely to fall backwards because you don't have any of that support, any of that ability to correct yourself. And so, little posture break, everybody. Kind of sit back, squeeze the shoulder blades. And this is something that, you can partially help. And there is some evidence that the exercising can reduce the standing height. And so let's prevent the shrinkage as we get older. And another interesting study by Senaki was the back extension exercises. And so what they did was they took a group of, I think, women over 50, and they made them do an exercise like this, where they were just laying down flat on their stomach, and they just kind of pushed up. And so that kind of would correct that forward flex posture, getting them out and up. And what they found is kind of a huge reduction in the spine fractures. So those who did these exercises had a 1.6% chance to get a fracture 10 years later, whereas those who didn't do the exercise had a 4.8, I believe, percent chance to get the fracture. So they only did this once a day for, I think, 10 repetitions. And it was quite remarkable, the result. So they did it for 2 years, and then they stopped doing it. And then they looked at these participants 10 years later and saw who had a fracture and who didn't. And so by doing this once a day, I mean, it takes about 15 seconds of your life and, can help reduce the vertebral fracture. So I found that quite amazing. All right, so here we have cat potato here. And so bad to the bone. And a striking result I found was that older adults spend 80% of their waking hours sedentary, either in bed, sitting down, not doing anything. And this is where I kind of want to change that. So I hope that's not the case for you guys. But if it is, hopefully this talk will change that. And those who participate in activity had a much lower hip fracture risk. So men almost by 50%, women by almost 40%. And the reason why that's important is because if you don't do activity, you're not loading the bone. And they took a group of younger adults, I think they're in college because they needed money to do this study, that they made them for 60 days just lie in bed and not do anything else. And then what they found was a 2 to 3% bone loss. And that's over a course of 2 months. And in addition to that, there was a decrease in their leg muscle size, the muscle mass, and a 40% decrease in their quad and their thigh strength. And then we think about the older adult spending 80% of their waking hours not doing anything. It highlights all of these where you have the bone loss, you have the muscle weakness, you have the decrease in the muscle size. And similarly, like with astronauts too, if they're up in space where there is no gravity, they found that it's like a 1 to 1.5% loss of bone mass a month. And so now they put weights on them in space so that they don't lose that as much. And so bad for the bone. So I'll get into later on how you can do some exercise, some activity to get us out of this cycle of being sedentary. Okay, so I wanted to brush on some educational points before I get into the exercises on what to avoid. And so the forward bending, this guy, is not a good one, because if we go back to the posture and the hyperkyphosis, that would add more compression to the spine, increasing your chances for a vertebral fracture. And then this is just kind of a fall prevention. If it's raining, if things are slippery, just be very, very careful. That's not a time to go out and walk. So be smart about it. And for abdominal crunches, this one, they did a study, I think again by Senaki, where they looked at patients who did exercises, especially abdominal crunches. And I don't want to lie to you, so let me make sure I got it right. That the spine flexion here, where he's kind of bending forward, is the position that most stress the vertebral bodies. And they found that 89% of the women, the postmenopausal women that did this as an exercise, 89% had vertebral fractures after 2 years. So then like, oh, no. Now we're not going to do that one. And so that's why that one should be avoided, and other types of abdominal exercises are recommended. So 89% had it in 2 years. And so what do you do? So to take care with the transitional movements, there's something called frailty fractures, and that's where you get a fracture by coughing, by moving in bed, by turning, by doing sitting to standing. And so you want to make sure that with these movements where you're transitioning from the bed to standing, that you take care with that. And I'll show a slide after this about bed mobility that can help. But being careful with that. And then good posture, we already talked about the kyphosis. So have everything stack up on each other so that there's no pressure more in the front than in the back. And then maintaining a healthy weight. Don't be too skinny. Plus size is in. Removing the clutter, optimizing lighting. So that's a huge one. A lot of times I get patients who fall because they didn't know that there was an extension cord, and they tripped, and there wasn't lighting. They were going to the bathroom, and it was at night because they woke up, and then they tripped and they fell. So make sure that you guys do make those adjustments at home. And instead of bending forward, making sure you squat, bending at your hip and your knees so that you aren't bending forward using your back. And going along with the transitional movement, sitting down slowly, making sure that the back of your knee is touching the back of the chair. And a lot of times people just assume that it's there, and sometimes they miss it. And that's how you can also get the vertebral fractures as well. And Dr. Kure mentioned using an assisted device. I am a huge proponent for that. If you don't feel safe walking, it's a huge confidence blow, but I'd much rather you use a cane, use a walker, than have a fall. And I put this review medication just to make sure that there is no overlap or there's no side effects where it does make you woozy, does make you out of balance, give you that vertigo symptoms. Okay, so this was taken from a colleague. I stole it. And so if this is you laying in bed, and you want to keep your spine in a good alignment, you want to make sure that you first roll over, and then you swing your legs to the side and then coming up that way. A lot of times people just come up that way, and then that's a lot of that same flexion motion. And so this is a good way to avoid that. All right, so kind of was touching on it earlier, why exercise? So exercise provides a huge weight-bearing component, unlike being an astronaut where you're pretty much without gravity. The bones, they like the weight-bearing, and so the bone loading, the compressive force straight down, helps to stimulate those osteoblasts, reduce the osteoclast activity. But in addition to that, there is a nice pull that the muscles, when the muscles attach to the bone, they can pull at the bone to then also create some type of force to it so it grows and it adapts. And additionally, exercise has a role with releasing hormones, your growth hormone, your prostaglandin, estrogen, all of which are very important in maintaining good bone health. And so in terms of the research, they found gymnasts versus non-gymnasts, gymnasts had much higher bone mass. And even in a dominant versus non-dominant arm, they looked at racket players, tennis players, they had a 19% increase in the size of one of their forearm bones. So there's a huge component of why exercise can help. So how do we exercise? What do we do from here? So first I'm going to talk about resistance training. This is where the muscle can pull on the bone to get it stronger. But there's also a big component where it does provide some force for the bones to grow as you push. And so this has to be lifetime. It can't be something you just do a little bit and you stop, as we talked about earlier. It will kind of revert back. And so a lot of studies, they looked at it for greater than 12 months, and then they saw an improvement 1, 2, 3% in their bone mineral density, bone mineral content. And the frequency I'm recommending for you guys, 3 to 5 times a week, go to the YMCA, take some classes. And it's a little bit different because when you're trying to build bone, you want to have a high amount of load, a high amount of force. That's how bones adapt. And so the intensity is going to be pretty high. It's going to be around 6, 7 out of 10 intensity. So where you can only do about 8 to 10 repetitions, that you can't be doing 15, 20, 50, that you have to be pretty tired and pretty spent by that 10. And then it's recommended that you take a little bit of a break because if you just kept going and kept doing it, the bone starts to adjust and it doesn't receive that same stimulus. So if you kind of exercise, take a break before the next set, it will help promote bone growth. And if you haven't exercised before, really, really start slowly. I don't want you guys to exercise and then get an injury and say exercise sucks. It's just what happens a lot when I see patients. You hurt me. But then slowly increase it. So if you need to do a rep of 15, 20, try the 20 pounds first on the machine, and then slowly start increasing the weight until you can get to this 7 out of 10 intensity to these 8 to 10 repetitions. So it's recommended that you work on all the major muscle groups, working on the chest, the glutes, the thighs. Leg press is a really good exercise. A leg extension on that machine is good. The leg curls. And the machines are a great place to start if you're new to exercise. It's a very safe mechanism for you. And from all the studies that they've done with the resistance training, there has been no true adverse negative effects, no fractures, no increase in falls compared to the group that didn't do exercise. So this is a very a good opportunity for you to improve your bone strength. And as a complement to that is the balance training. So this won't necessarily build your bone strength, but then it will prevent the falls that cause the fracture, which is the most important thing for you guys. And this is another lifetime thing. But as opposed to resistance training, which is 3 to 5 times a week, balance training, you really can do as much as you want. Say you're cooking, balance on one leg while you stir the pot, whatnot, because it's more so a nervous system connection from your brain to your muscle to your joints to give you that stability. And the more you practice it, the stronger that nervous system connection becomes. And whenever you're free, I always tell my patients, do something, do an exercise, balance, so that you can improve it to prevent a fall. And so I just put a few things here. So balancing on one leg is a very nice thing. Make sure you are next to a counter or something that you can touch if you need to. If that's too difficult, we call it tandem balance, where you put your heel and toe right next to each other, and then you can balance as well. You might feel a little wobbly that way. Or you can combine walking with head turns, head nods up and down. Because a big thing with falls is that you usually fall when you are multitasking, when you're doing more than one thing. If you are walking, carrying groceries, talking on the phone, and then you don't realize that that you are tripping over the curb. Okay, and so here's a few other things, the high impact, the jumping. They recommend something like 2 times your body weight. I'm going to get into a little bit of the exercises afterwards. But same thing I talked about, taking the rest break so that the bone doesn't get used to that same stimulus, the same loading. And walking was an interesting one, very controversial now in the research, showing like no to minimal effects on the bone. And so what I'm recommending to you guys is it has to be something that is more than your current activity. If you're already walking 30 minutes, it's not going to help promote your bone. It's just going to maintain it. So I recommend more brisk walking, hill walking. A lot of the stairs would be good to help load it. But it is very helpful for elderly women, they found in a study. And if you increase your steps, so more than what you normally are doing, is what's going to promote that osteogenic, that more bone building stimulus for you. Okay, so talking about a few exercises. How am I doing on time here? Are we okay? Okay, we're gonna speed it up. So I'm just gonna slightly demonstrate. So with wall push-ups are a good one because if you fall and you land on your hand, that's where you get a lot of the forearm, the wrist fractures. So doing the wall push-ups will help build that strength. So just kind of pushing up here and then coming back. That would be a good one, a very safe one. You determine how far away to be from the wall. Sitting to standing, sitting up fast to build up that muscle power and strength, and then slowly sitting down. And then you have forward lunges, coming this way, coming back. And it's nice to hold on to something if you don't feel safe. And then same thing with the sideways. You can just come to the side, come back. And step up and down, which I was mentioning with the stairs. It's a good exercise to help get you stronger. Now some of the loading ones, which really helps build up your bone, are heel drops. So coming up onto your toes and then coming fast down into your heels. That will help provide that extra body weight to go through the bones to build up strength. Another is jumping jacks. But if that is too difficult, you can hold on to a table and then just kind of going back and forth like this, just hopping. And then that hopping will help promote some of that strength. All right, so now what? I want to give you guys the tools, make sure that you guys take home something meaningful. And a lot of times people, they don't like to exercise if they do it by themselves. So these are good avenues for you to go to. Torrance Memorial has a lot of classes that they offer. This is a number you can call to register. This is a website that's currently down, but hopefully it'll be up soon that you can look at for the classes. Silver Sneakers is a program where you can go sign up for gym membership, city-sponsored classes, and water aerobics is a nice one if you've had a fracture before and you want to make sure that, I don't want to get into it too quickly. Water aerobics is a nice one, which is very gentle. It's not as good as land exercises, but it still helps to promote that same strength. And Yoga for Osteoporosis is one that I just came across in the past 2 weeks by Debbie Robinson. Is she here? So can you stand up? So she teaches a course called Yoga for Osteoporosis. It's specific for osteoporosis, and talking to her, it's great. She learned from Dr. Fisher, and based on the studies they've done, they found 7-8% improvement in bone mineral density of the hip and spine, and she's really good, very knowledgeable with that. And you can sign up the same way through the Torrance Memorial classes. All right, and then I think I am done here.
Okay, a wow presentation. We're now going to take a short break. I'm going to try and hold it to 5 minutes. Good luck.
Did I go over?
And members of the Miracle of Living Committee will be coming around with paper, and if you need it, pencils for your questions, and then we'll come by again to collect them. We don't take questions yelled out from the audience, so please write your questions down, and then our panelists will address them right after the break. Thank you. At least I know a couple of these, at least I know who to aim them at, because it says, Dr. Cooray, can you speak about the high doses of vitamin D3 that have been recommended?
Can you hear me okay? Okay. So vitamin D comes in a 50,000 international unit prescription. It's given once a week, and we usually treat for 8 to 12 weeks. We typically don't go beyond this. After the 12-week mark, we may check the vitamin D level and then recommend a maintenance, which is usually taken over the counter, to between 2,000 to 4,000. The recommendation from the National Osteoporosis Foundation is that patients take no more than 4,000 international units per day. I do want to mention that in those with kidney disease, we actually defer vitamin D treatment to the nephrologist. As I mentioned to you before, vitamin D is a supplement you can become toxic on. And so a lot of patients with kidney disease may have low vitamin D, but usually the nephrologist may not treat that because that can come from other, factors. But in answer to your direct question, 50,000 international units per week is the prescription strength. Is that sufficient?
Okay. Let's see. A couple of questions about are plant-based or coral calcium better than other kinds of calcium supplements?
I'll take that. So if you can get calcium from your diet, it's much better absorbed. And so if you can get it from a plant-based diet, more power to you. It's much better than taking supplements. I can't say that coral calcium is better. It's actually thought that calcium citrate is probably the best absorbed if you're taking a supplement. So if you're not able to adequately get enough calcium from your diet and you're having to take a calcium supplement, then calcium citrate is what is recommended.
Okay, let's see.
No, that one is not plant-based. Yeah.
I think this is probably Dr. Gamboa, but I'm not sure. Can a cervical vertebrae that has bone loss be reversed? Will calcium and vitamin D help rebuild it?
So the way I would answer that question is it depends on how much, as how much your T-score, how much bone loss it is. As you know, those are building blocks. But if it's very, very bad or very, very not as dense, of course you have more room or a lot of ground to cover. And this is where medications come in. That's why we recommend them, because they're able to cover that ground.
Thank you.
But yeah, calcium and vitamin D, as we mentioned, can play a part in building the bone. It just depends on how much bone you have to cover. If it's a lot, may take a long, long time and may not worth waiting that long to do. If it's just a little, it might be beneficial. But again, it all depends on how much bone loss you have to cover. And there are alternatives, but it all depends.
Okay. I think this is from someone that does yoga classes. When squatting, what is the best way to come up?
Hello? Is this on? On? Working?
I think what's meant is, come up slowly or jump up, or is there a particular method that is preferred? Demo time, folks.
Let me demo a little bit. So, did someone want to raise their hand if they asked that question, just so I can see how they're doing it?
Down here.
Okay. Did you want to show me how you're...
I've heard different things. Like the way I've done it is to go down like this and then push up with the hands. I've heard that it's bad on the knees to keep going down and up.
Right. So, if you're going to be down and pushing off with your hands, do you realize that that brings that same position then
Well, I'm
where
pushing up like this.
that way? Okay, so that's a lot better than kind of pushing up, straightening the knees, and then coming back up. That's what you want to avoid, because then you end up here where you're just kind of bending at the spine there. So a lot of times we recommend like a big hip strategy where you are kind of bending back here, and then as you come up, bring your butt forward. And then you use more of the buttock muscles, which is less strain on both the knee and the spine.
Okay. I don't know who should tackle this one, but does osteoporosis or increased calcium supplement put one at risk for vertigo?
As far as I know, not directly. Of course, there's always indirect things. What is the cause of the vertigo? If there's a fracture involved, etc. But as far as I've read, not directly. And it's because osteoporosis is due to loss of bone density. But of course, a lot of different things indirectly can come from it that I've mentioned. So not directly from what I can tell, and also not calcium directly from what I can tell. But indirectly, there might be some steps that lead to it. It could be a stretch as well, but not directly is how I will answer that.
Okay, what are the side effects of infusions like Reclast?
So similar side effect profile to the oral bisphosphonates. There is also always the potential of an infusion reaction. With Reclast, flu-like syndrome has been described, and typically this is self-limited. It will last a few days and then usually is just resolved with supportive therapy. You know, historically, there were reports of atrial fibrillation or irregular heart rhythm that had been reported, but in more recent studies, that's kind of been refuted. The main contraindication to Reclast, as well as all the other bisphosphonates, is kidney dysfunction. So if you have kidney disease, this is not a medication that you can take. So I think probably the biggest separating factor between Reclast and the other bisphosphonates is the flu-like syndrome, as well as potential for infusion reaction. Rare, but it's there. Oh, one more, I'm so sorry. So also rare reports of inflammatory eye disease have been mentioned. And it's hard to say. I mean, these have been reported with the other bisphosphonates as well. And the occurrence seems to be slightly more with the infusion. Keep in mind that these bisphosphonates have a very long half-life. So even after you stop these medications, they can linger in your bloodstream for about 10 years or so. So that's why we can, you know, they're often stopped after 3 to 5 years because, you know, they linger in your bloodstream. So that can be good and that can be bad. But anyway, so those are the side effects.
Okay, is a loss of inches in one's height possible without actually having compression fractures? This person says, over the years I have shrunk 3 inches. My DEXA scan shows osteopenia, but no fractures.
So it could be possible, but of course you want to rule out different things that can cause it. The amount of posture, or if there's other bones that have been compressed or are changing, essentially. So you're doing the right thing. You're making sure that you try to check the density of your back, but also x-rays or checking the height of the vertebra can also be done to see. And definitely because of osteopenia, you are at risk for leading to osteoporosis. So that's important. So basically, so I'm not dodging your question, if everything's checked, I would check in other directions if everything from the spine is not causing it, because that can also lead to loss of height as well. But you're doing the exact right thing.
I'm going to add on a little bit to that. So also as you get older, there's a disc between both of your vertebrae. And as you get older, that water disc starts to shrink and becomes smaller and smaller and smaller. And so that plays a role in your height as you get older. And they found that you're most hydrated in that disc in the morning after you've been sleeping, where it finally opens up, and then you get a little shorter as you get through the evening and the night. So measure yourself in the morning. But also with as you get older, we talked about how the bones adapt. And so if you're chronically in a forward posture, the bones start to remodel and change into that position. So then the vertebrae start to be shaped like that too. And so as you start to develop more of that curve, the bones kind of follow suit. And that way you can also lose height in your spine.
If let's see if I understand this question. If a bone is broken with a compression fracture, I presume this is in one's spine, I'm not sure, wouldn't you have pain?
Yes, that is correct.
Okay.
But of course, so it's the compression that causes the pain. It's not the loss of the density, it's the compression that causes the
Okay.
pain.
Let's see. For Aaron, what kind of abdominal exercises would you recommend instead of crunches?
That was a great question. I probably should have put that in my presentation. I think it shocked a lot of you who do it. You're like, oh no, not that exercise. And so I had a nice lengthy discussion with a couple of you guys. And so this is where I recommend doing more stabilizing abdominal exercises, such as planks would be a nice one, or where you are laying on your back and you have your legs kind of up, so you're...
Demo.
Gotta go on the floor for this one. So, good thing I have no shame here. Okay. So, planks look like this. If that is too difficult, you can go onto your knees, keeping your ab muscles tight. It's a nice one because it doesn't require very much spinal movement or twisting, and that you just work on it that way. And then if you want it harder, just go up onto your toes. And the other one is keeping your ab muscles tight this way, and then you can do like a kicking out, or you can do a tap, keeping the ab muscles tight as if you're coughing, and then you'll feel the ab muscles push out. A lot of times, patients, when they brace their abs, they suck in. And when you suck in, you don't put your ab muscles at an advantage. And so what I mean by that is if you brace, you provide more abdominal pressure, which then stabilizes the spine, because these oblique muscles on the side actually wrap a little bit over midline and all the way back to your spine. So if you can brace, increase the pressure, then you can stabilize your back and not put so much compression on your spine.
Okay.
Brace, where you cough, make it tight. Yeah, sorry, great question.
Okay, I think, I'm not certain which presentation this was, but its reference is page 16. Which anti-seizure meds are to be avoided? This has to do with risks for low vitamin D.
So, I think ultimately this is a conversation to have with a neurologist as to what the right seizure medication is. But Dilantin actually is one that can increase risk of bone loss and perhaps vitamin D absorption.
Okay. Someone suggests they've heard that calcium should or may be more effective if taken with magnesium, or does that matter?
The data is not as robust, but magnesium also, just like vitamin D, can be important in calcium metabolism. But there is no optimal dose of magnesium per se that is recommended. And so as much as possible, we recommend to patients that they do try to get it, from their diet.
Okay. seniors have been advised to do low-impact exercises. Now I hear percussion on bone is good. Maybe we've covered this, I'm not absolutely sure. But you've talked about jumping jacks, for example, that kind of
Right. So there's a fine line that you have to play with how much to load the bone versus how strong the bone is. And so if you have osteoporosis and you're wanting to exercise, starting off with the low impact might be a good idea, and then slowly start to increase the amount of force the bone is used to. Much like a muscle, you can't just lift, or squat 300 pounds. You have to start, a little less. Start at just your body weight, then the bar, and then add the weight. So same thing with the bone to make sure that you slowly work your way into it.
There, somewhere in your presentation, I think it was Aaron, what did you mean by 2 times your weight?
So the 2 times your body weight is kind of a way for them to measure in research how much. And so in running, for example, that is 4 to 8 times your body weight potentially. And so when I say 2 times your body weight, doing things like the small kind of jumping jacks or the pushing off with a quick lunge, those are things that would be more towards like the 2 times your body weight. And they don't recommend doing more than 4 times your body weight if you have, severe osteoporosis.
Okay. We have more questions I know what to do with here. Let's see. Here's a person who is on Prolia. What will be the best way to replace Prolia?
So, provided there's no kidney issues, oftentimes what ends up happening in patients that have been on Prolia is we switch them to a bisphosphonate. As I mentioned to you earlier, the bisphosphonates do have a very long half-life. And those medications, potentially, you can stop. So, for example, this situation comes up quite a bit where a patient's been on Prolia for a period of time, and they decide, I don't want to continue getting an injection every 6 months, so then they may switch, again, provided there's no kidney issues, might go to Reclast and be treated for a couple, 2-3 years, and then just stop. Or they can go to an oral bisphosphonate as well, and they may be treated for a short period of time and then stop.
Okay, here's a person who says, 2 years ago I had spinal stenosis surgery. My discs were fused in my neck. Now I find myself walking with my neck bent and protruding forward. Am I developing osteoporosis?
So the hard thing to say about that question is because with the manipulation, there's a change in the bone density. So that's difficult. The best way to answer that would be to check the other areas, like the lower back, and to see what the bone density is and those areas to see if it is consistent with osteoporosis. But it's hard. So a lot of times we have to go with other areas to see if there's osteoporosis changes, especially if there's a lot of manipulation. So it's hard to say exactly in those areas if there's osteoporosis, and that's why we check different areas to see if there's osteoporosis. So I'm not dodging your question. It's hard to say exactly, but in that case, I would check other areas. Because if you have osteoporosis in other areas, then you have osteoporosis. There's no argument about it. But if it's not, then we have to consider other things if there is osteoporosis.
Okay, here's someone, I think I'll just read this whole thing. My question is for those of us that have celiac disease, Hashimoto's thyroid, and osteoporosis. What are your suggestions to help slow down the progression of this disease and the effect it has on our bodies? Do you know anybody that specializes in treatment for this?
So endocrinologists actually do specialize in treatment of Hashimoto's thyroiditis. And so the short answer to the question is it's important to get the thyroid disease under control. Celiac disease is often treated by gastroenterologists. Now, the bottom line is that the big contributor of celiac disease to osteoporosis is vitamin D absorption, or not being able to absorb the proper nutrients, and thereby they may have low bone density or low body mass index, that increasing the risk of osteoporosis. Probably a little bit beyond the scope of, trying to identify the right medication, but the short answer is that both those diseases should be controlled as much as possible to aid in strengthening bone mass. And then if both the diseases are under control and the patients are still osteoporotic, typically we would go to an agent that is either infused or injected, as these are absorbed much better. Patients with celiac disease often have absorption issues, so giving them an oral agent may not be doing them a huge service.
Okay, and in general, well, let's see. Yeah, in general, a lot of questions about calcium supplements. In general, should we take a calcium supplement if we don't think we're getting enough through food?
I don't carte blanche advise patients to take calcium if their calcium levels are normal. So when you have your labs done through your primary care doctor, and you probably have a basic metabolic panel or a comprehensive metabolic panel, that will give you a calcium level. So if your calcium is low, then yes, you can take a calcium supplement. If it's not low, if it's within range, then you don't need to take extra calcium or take a calcium supplement. I would still encourage you to try to get calcium through your diet. That's a good thing. Again, calcium through the diet, through food, is much better absorbed. It's much more beneficial to our bones. So I'm not a huge proponent of supplements unless it's needed. Calcium in excess actually can have harmful effects as well. It can increase risk of kidney stones, which are very painful. And so I don't recommend calcium supplementation to patients who have a normal calcium level.
Okay, there are, I'll tell you before we go forward, a few questions here are extremely specific to people, and I'm not going to relay them to the panel because basically the answer is going to be, please go see your own doctor and go over all this very specific, symptoms and medicine interactions and all that sort of thing. But here's, more general question. I have osteoporosis, but very scared about the terrible side effects from these various drugs to treat this condition. I went to a pharmacist and looked at all the literature and apparently was really terrified by it. What should I do?
This is a very, very common question. And we worry about that too on this side of the fence, because before I prescribe a medication, I too am worried about what kind of side effects they may have on patients. So it really does become a balancing act. We look at all the factors. First and foremost, what are your risk of fracture? How low is your bone density? So you have to realize that when the bone density is very low, when you have very low low density scores, there's very little you can do with supplements to improve bone strength. As Erin mentioned, if you're younger, there's a higher risk of building bone, but as our bodies age, we lose that propensity. So we are having to rely on these medications. Basically it's important to look at what your other risk factors are. If you have kidney disease, if you have heart issues, if you've had a history of radiation therapy, those kinds of things. So I guess the short answer to your question is that to realize that the risk of fracture truly is much higher than the risk of these potential side effects. They're not that common. I think we hear them and then we get scared about the side effects and not realizing that, that fractures can be devastating. People they don't die of the fracture itself, but the sequelae of the fracture, right? Laying in bed, developing pneumonia, blood clots, heart attacks, whatever. And so that is very real. So you kind of have to weigh those pros and cons. It becomes a very individual decision, I hear you. but it is something to be taken very seriously. So I would caution you about, getting sidetracked with just reading the side effects, because the reality of it is that those are very, very rare.
Okay, let's see. This is fairly specific, but I'll inject it in anyway. I just finished my Forteo shots and am experiencing pain during the night in the legs. Is this a side effect of stopping the injections?
I'll try to answer that. So if the Forteo is causing the pain, then what Dr. Cooray was alluding to is we have to weigh the risks and the benefits. Again, how bad do you need the Forteo? How bad is your T-score? Is there a high risk of fracture? Then it might be worth continuing, because as you know, Forteo is for 2 years. So there's an end game with Forteo. If it's bothering you that much, then I would look into other modalities if there are side effects for it. If you're asking if stopping the medication would cause the pain, I know, it depends on how bad your T-score is. Stopping it can lead to fractures depending on the T-score. Forteo is one of the strongest medications out there, so it's usually recommended if there's breakage or if there's a high risk of fracture.
I'm sorry, did the patient already finish the 2 years on Forteo? Is that what they're alluding
I
to?
think that's the case,
Okay.
and now it's a case of having pains in the legs.
Yeah. I'm not aware of any of that type of data. One thing I can tell you is a lot of these osteoporosis medications can cause remodeling. And so thereby you can develop body pains, myalgias, arthralgias, while you're on the medication. But if this has happened after the medication has stopped, one thing to look at is to make sure your vitamin D level is okay, because when that's low, that can cause a lot of bony pain. So directly correlating that to stopping Forteo, I'm not aware of any such data.
Okay, here's someone that says they have osteoporosis in the L1, L4. I presume that's the lumbar portion of the spine. What kind of weight-bearing exercises are spine-specific?
For the spine specifically, it's a little different than the hip strengthening bone-wise. And for the hip, a lot of times a lot of studies showed that the non-weight-bearing exercises seem to help a lot. So doing like the leg extension, leg curls seem to help. But with the spine, they found it's multi-componented. So you want to make sure you do some type of aerobic activity, whether it be walking, step aerobics, you name it, and then combining that with a strength program where you do those ab exercises, you do multiple different strengthening leg workouts. So it's a little difficult to answer that question for the spine because a lot of the research says kind of do all of it. That's how you know we're really unsure right now. Just do it all and then it'll help you. Sorry about that.
Okay. Let's see. I think this is a publication, I'm not sure. In Bottom Line Health, they said new slow-release fluoride supplement combination builds 6% more bone mass in 1 year. Is this true? Has anybody heard of this?
I am not aware of this data.
Say what?
I'm not aware of this.
Okay. All right, well, here's Adolf. Here, a simpler, is goat milk considered bad dairy?
If you can tolerate goat milk, more power to you. I've had goat milk, not a fan. But, it is, I would assume it's dairy. It's milk, yeah.
Okay, let's see. A couple questions about walking. One is power walking at, say, 4 miles an hour helpful? What about your thoughts on walking sticks? I'll leave it at that and turn it over to Aaron.
Yeah, that's a good question. I think a lot of times when you have the diagnosis diagnosis of osteoporosis or any type of condition, it's recommended to walk. And from the literature out there, it shows that it's kind of a hit or miss as to whether it helps build bone or if it doesn't have any effect. And this is where it could even have adverse effects. If you're walking, you have more chance to fracture, more chance to fall versus someone who is inactive just watching TV. And bringing up the walking sticks, that's a good alternative if you don't feel like your balance is good. And if you don't do that, if you need a cane, if you feel unstable, use a walker. Be smart about it, because this is where you're trying to improve your bone and your strength, not necessarily try to improve your balance with it too. So you should make sure that your balance is up to par so that you can step onto the curb, so that you can manage going downhill, uphill. And I think there was a first part to that question, which was the 4 miles per hour, I believe. And so you just want to make sure that it is an activity that your body isn't used to, that it's faster, it's more demand than what your typical is. Because if it's your typical, then your bone is used to it, your muscles are used to it, so there's no new stimulus, no new demand for the bones, for the muscles to likewise adapt. So if you're just looking to kind of maintain, then that will be excellent. But if you want to get stronger, get the bones to build, you'd have to increase the steps, increase the intensity by going up down hills, by putting on like a weighted vest or doing something to where it would provide that extra stimulus for you to grow.
I really like this one. Is it true that drinking beer in moderation is good for the bones?
I've never heard that.
Let's see, I know we have to wrap it up very quickly here, and I've got about, okay, effect of Prolia on blood pressure, question mark?
Yeah, that's an interesting question. So to be truthful, I don't know that it's reported in the package insert, but I've had a couple of patients that have experienced this. It has also been demonstrated with Forteo. So generally, if the blood pressure really spikes, then I may not treat the patient again with Prolia. But I have had a few patients, not very many, but a few that have had high blood pressure with Prolia. Yeah. Why? I'm not sure. I don't know if there's sodium in the injection, and that's what, their blood pressure is very labile, and that caused them to spike. That may have been, or they were very anxious when they had the injection. That could be as well.
Okay, let's see, one further question on exercise. Many people exercise in the pool doing water aerobics and swimming. Do either of these forms of exercise contribute to osteoporosis prevention? And what about Pilates?
So that's a great question. Talking about the water aerobics, the swimming, it helps to really improve your strength. It's been shown to improve your balance, and it's not as good compared to land-based exercises, jumping, plyometrics, weight resistance on land, because exactly there is a weight bearing. And so when you're in the water, it kind of takes the weight off of the legs, and so then it doesn't have that strong compressive force to stimulate bone remodeling, bone growth. And so the systematic review of like a compilation of articles was showing that it was very, very minimal, if anything, in terms of improving the bone. But the land-based exercises kind of beat them out in terms of both the resistance training for strength, for bone, and for balance. And so I did recommend the water aerobics, the swimming, as a nice gentle start to initiate, to get you used to exercises, but it would be more beneficial if you can handle it to try the land exercises. The Pilates would be a great one for the spine. Yeah.
Okay. I'm not quite sure what this refers to, but please discuss side effects of yearly infusions.
Reclast, I think we covered that earlier, no? The reclast, yeah, I think we covered that.
Okay. Yeah, maybe I want to answer this one myself. The question was, you state there's not very much data on calcium and vitamin D's effectiveness in reducing fractions. Why do you recommend them? I think the answer is because they build bone, right? And that in itself will...
So this is actually more of a prevention than a treatment for osteoporosis. So I think, you know, that distinction is important to make. Once you have osteoporosis, and that's what I was trying to highlight, calcium and vitamin D are not going to help build up bone, but it's an important preventative tool in patients that don't yet have osteoporosis or are in the osteopenia category.
Right.
Does that make sense? Hopefully.
Yeah. Two last questions. Why are there time limits on bisphosphonates?
So bisphosphonates have a very long half-life, as I mentioned. So the longer you're on these agents, the higher the risk of those side effects that we discussed. Atypical fractures, osteonecrosis of the jaw. Those are the two biggies that we worry about. So if you're on these agents for prolonged periods of time, they just build and build and build in your system. So generally speaking, you know, even after you stop the medication, they're already going to linger for 10 years. So theoretically, these are not medications you just want to stay on for the rest of your life. You know, so we typically do no more than 5 years. In the case of reclast, it's only 3 years.
Okay, and last but not least, apparently this person has had a thyroidectomy and is taking Synthroid and will be doing so for life. Is this a risk factor for osteoporosis?
So the thing with that question is you no longer have a thyroid, so you are replacing it with thyroid supplements. So of course you don't want to overshoot that and take too much thyroid, because that can then lead to osteoporosis. If you're taking it for life and everything is normal, your euthyroid or normal thyroid, it shouldn't be a problem, but of course you would talk to your endocrinologist who would be monitoring it and could also watch for osteoporosis as well. So it's a fine balance as well, and I would talk to your endocrinologist or whoever's replacing your thyroid medication to make sure that it is enough and you're taking the right amount, because going over can cause some issues.
Okay, that is it for Q&A, and thank you to our power panel.